Hi, my name's Kristin Brown. I'm an Assistant Professor of Neurology here at UTHealth in Houston, and I'm a member of the Neuromuscular division of the UTHealth Neurosciences program. And today I'm going to talk to you guys a little bit about polyneuropathy, also kind of commonly referred to as neuropathy. So we're going to start off our discussion with what is neuropathy. It's a disease or condition affecting the peripheral nervous system. So that we have a better idea, I'm going to do a brief review of the nervous system. So it's divided up into two parts. So the first part, the central nervous system, also referred to as the CNS, involves the brain and the spinal cord. And then we have the peripheral nervous system, which are all those nerves that come off of the spinal cord. So the nerves that go into our arms and the nerves that go into our legs. So polyneuropathies generally affect the peripheral nervous system, so those distal nerves in our arms and legs. Peripheral neuropathies are actually quite common. About 2.4% of the general population will be diagnosed with a polyneuropathy, and about 8% of individuals older than the age of 55. The vast majority of peripheral neuropathies are chronic and not life-threatening, but some can unfortunately produce significant disability. So when we think of neuropathies, or at least generally when I think of them, I kind of try to divide them up into the pattern of involvement. And they kind of come into two variations, length-dependent and non-length-dependent. So length-dependent neuropathies usually affect the longest nerves in your body first. So if we kind of think about it, the longest nerves in our body are actually the ones that are in our legs. And what you'll commonly see with that is something that we will call a stocking glove distribution. And this picture here, over here on the right, kind of displays that. So what you'll see is as the neuropathy kind of progresses up the patient's legs, they'll start to develop symptoms in their hands. And this is the stocking glove distribution, kind of similar to a stocking and a glove that you would see in length-dependent neuropathies. We also have some neuropathies that are non-length dependent, and they don't affect the longest nerves first. So some of these patients might notice that their symptoms are worse in their arms than they are in their legs. So what are the symptoms of polyneuropathy? Usually what patients will come in complaining of is either numbness, so like sensory loss. I've had patients describe it to me like they feel like they're wearing socks even when they're not. And paresthesias are odd sensations, so things like feeling like ants are crawling or pins and needles, or feeling like their feet are cold, but if they kind of touch their feet, they realize that their feet aren't cold to the touch, but they actually feel cold. And also dysesthesias, painful sensations. So I've had patients describe it as feeling like they have hot pokers in their feet or that they're getting electric shocks in their legs. Some people will also feel like they have like stabbing feelings in their feet and toes. Another common complaint is weakness. So people will notice that maybe their grip strength is a little bit weaker or they're having some weakness in their toes. So also what we commonly see is poor balance. So patients will have a wide-based gait. So they'll kind of walk with their feet kind of spread apart. And usually they do that to kind of help with their center of gravity. We'll also see that they are what we call ataxic, which is kind of fancy for kind of walking like you're off balance. And this can sometimes produce frequent falls. So in this picture, I wanted to kind of give an example of what we can sometimes see in the weakness, because we'll also see something called muscle atrophy, which is thinning of the muscles due to the neuropathy. So over here on the right, this is a patient's hand that's completely normal. You see that you can't really see the bones in the hand. The muscles look kind of large and healthy. And then if we compare it over here to the hand on the left, you can see that there's atrophy, so thinning of the muscles. And you can see that even in the intrinsic muscles of the hand, that you can see that they've kind of thinned out, and you can see the bones in between, the bones in the hand leading to their fingers. And this is a lot of what we'll see sometimes when neuropathies will get pretty far advanced, that patients will start to develop atrophy in some of the muscles in their hands, sometimes in their feet and legs. So the long-term complications of neuropathies, some patients will develop hand weakness and clumsiness. I've had patients come in and say that they've changed their clothes, so they don't wear clothes that have buttons or zippers because their fingers are kind of clumsy or they can't really feel where their fingers are. Lots of gait instability, so feeling off balance when they're walking, feeling like they're having a lot of near falls. Some patients will have difficulty walking where they may not just necessarily feel off balance, but they're having actual weakness where it makes it difficult to walk. Because of the gait instability, there will be frequent falls, and sometimes in the more severe cases, patients will have difficulty with their ADL, so meaning if I'm having a lot of weakness or gait instability, maybe I'll need help getting to the restroom or help getting in and out of the shower, things like that. So how do we diagnose polyneuropathy? So I generally kind of think of it in a stepwise pattern. So when patients come in, the first thing I'll have them do is tell me about their history. So I'll ask them, when did they first start noticing symptoms? What are the symptoms that they're noticing? And I usually ask them, what is the thing that's bothering them the most? Is it the weakness that's the most difficult, causing them the most trouble? Or is it the gait instability? And for some patients, it's the actual pain, the neuropathic pain, the dysesthesias that are giving them the most trouble. Then based on that, I will do a physical exam. So I'll try to look for signs of atrophy, signs of sensory loss. Frequently with neuropathies, patients will lose some of their deep tendon reflexes. So I'll check the reflexes in their ankles and their knees to see if those are still present. Based on that, then I'll kind of decide if we need to proceed with electrodiagnostic testing. So here at our lab, we do EMG nerve conduction studies, which is an electrodiagnostic test of the peripheral nervous system. So what we kind of do is we'll put electrodes on the skin, little electrical shocks through the nerve, and that'll tell us how well the nerves are functioning. And then the second portion of the test is the EMG portion, where we'll put a needle in the muscle and we listen for the way the nerves and the muscles are communicating. And based on that, we can kind of decide the severity of the neuropathy and also help us to classify it, whether it's axonal or demyelinating. And that can also help us in deciding what laboratory tests we're going to send to decide about, to help us try to identify the cause of the neuropathy. Based on this, sometimes I'll also decide if I'm going to send a patient for a nerve biopsy, which is a biopsy of the nerve. So what we'll do is we'll send the patient to have a piece of the nerve taken out. And what we'll do is we have a lab here with our group, and our pathologists will look at the nerve under the microscope, and they can help us identify what might be the cause of the neuropathy. Sometimes I'll also send for a skin biopsy, which can help us diagnose small fiber neuropathies. And kind of sometimes more rarely, I'll also send for MR neurography, which is pretty much like an MRI of the nerves, which also can help us kind of identify what might be the cause of neuropathy. So there are lots of different types of neuropathies. So they kind of fall into kind of three major classes: large fiber, small fiber, and autonomic. So up here on the screen on the left, I have a picture of a nerve. So I try to describe, when patients come into clinic, I try to describe the nerve to them, the anatomy of the nerve, as like an electrical cord. So if you think about it, this outer layer, our Schwann cells are produced by the Schwann cells, and they're called the myelin sheath. They're kind of like the plastic coating or wrapper around an electrical cord. And they help to make sure that the electricity being conducted by the wires underneath conduct quickly and conduct well. And then underneath that are the actual wires or the actual nerve fibers. So large fiber neuropathies, they can either be demyelinating, meaning that they take off this myelin sheath, they affect this myelin sheath or the outside plastic wrapper around the nerves, or they can be axonal, where they don't really affect that outer sheath, that outer covering, that plastic covering, but they affect the nerve fibers underneath. Some neuropathies can be sensory only, meaning that the patients only have sensory loss, but they don't have any weakness. Or they could be motor only, meaning they affect the motor nerves only, meaning that the patients can feel everything, but they'll have lots of weakness. Or most typically what we'll see is that they're sensory motor, so there's some combination of both sensory loss and weakness. Then also we'll see small fiber neuropathies that affect the smaller nerves. And then you can also have autonomic neuropathies, so neuropathies that can affect the autonomic nervous system, which controls like heart rate and blood pressure. And these patients will have lots of issues with maybe having low blood pressure or having increased heart rates. And sometimes they'll have lots of issues with fainting spells and things of that nature. So I wanted to talk about also the causes of polyneuropathy. So I found this chart in one of the textbooks that kind of divides it up into the different kinds of neuropathies. So a very common form of neuropathies are sometimes genetic, but you can also have neuropathies due to medical illnesses. And then you can also have neuropathies due to deficiencies. So things like vitamin B12 deficiency can be associated with neuropathies. You also can have neuropathies due to endocrine conditions. The most common cause of endocrine conditions that causes neuropathies is diabetes. You can have toxic neuropathies, so like exposure to certain medications or certain heavy metals can cause neuropathies. Also inflammatory neuropathies, so things like Guillain-Barré or CIDP. These are typically thought of as like autoimmune neuropathies. You can have neuropathies to infectious things. Things like HIV can cause a neuropathy. You can have neuropathies due to paraproteins. And then there's this small slice over here, this class of neuropathies that are called idiopathic, meaning we don't know the cause of the neuropathy. So I wanted to talk a little bit about diabetic neuropathies. So diabetes is the most common cause of neuropathy in the United States. The prevalence actually increases with age and the duration of diabetes. So the older the patient is and the longer that they've been suffering with diabetes, they are at increased risk of developing neuropathy. About 50% of patients who've had diabetes for at least 25 years will have neuropathy. Typically presents with mild distal weakness, and it's actually the most important cause of diabetic foot. So how do we manage diabetic neuropathy? I always encourage patients to have really well controlled blood glucoses. So having your blood glucose being really well controlled can either prevent the onset of it, prevent or delay the onset of diabetic neuropathy, and it also tends to slow the progression. If a patient has developed diabetic neuropathy, foot care is really important. So I'll encourage patients to, every evening when they go home, to check their foot for sores or ulcers or cuts. It's also important that patients with diabetic neuropathy follow with podiatry. And it's also really important that they wear comfortable footwear, so not wearing shoes that'll kind of rub on their foot or on their heels that can also cause ulcers. Pain management tends to be very important for these patients because diabetic neuropathy tends to be painful. And also symptomatic treatment, so if they develop autonomic features, so for example, what we call orthostatic hypotension, where they stand up and their blood pressure drops and they feel lightheaded, or if they will develop tachycardia or a fast heart rate, things like that, we try to manage those symptoms for them as well. So inflammatory neuropathies, a very exciting class of neuropathies because they tend to be very treatable. One of those kinds of neuropathies is Guillain-Barré syndrome that has multiple variants, things like AIDP and Miller-Fisher syndrome. Also CIDP, or chronic inflammatory demyelinating polyneuropathy, which is an inflammatory neuropathy that's chronic, and also multifocal motor neuropathy. These neuropathies are generally treated with immune modulating therapies, things like IVIG and plasma exchange. Another kind of really interesting class of neuropathies are the genetic neuropathies. So we have motor and sensory neuropathies, the most common of which is Charcot-Marie Tooth, or CMT. Amyloid, which can have systemic involvement, so patients with amyloid neuropathy sometimes can have cardiac involvement. And Fabry's disease is another genetic form of neuropathy that is sometimes associated with stroke. So I want to talk a little bit about CMT. So Charcot-Marie Tooth, it's one of the most common inherited neurological disorders. It affects 1 in 2,500 people in the US, and it was identified by 3 physicians in the 1800s, Dr. Jean-Martin Charcot, Pierre Marie, and Howard Henry Tooth. So it actually comes in a couple of different types. CMT type 1, this is actually the most common form. People usually present in the 1st and 3rd decades of their life. It's autosomal dominant, and it's typically caused by genes, mutations in the PMP22 and MPZ gene. And most commonly what you'll see is distal weakness, so weakness in the foot, calves, and ankles. So PMP22 and MPZ, I thought we'd talk a little bit about these genes. I think PMP22 to me is probably the most interesting because it's the most common form for genetic malformation associated with CMT type 1, and it it's part of a protein found in the myelin sheath, that outer plastic layer that we had talked about previously. So it actually can cause, a mutation in this can actually cause two different conditions. So if you have too many copies of it, you'll actually develop CMT type 1. But if you have too few copies, you'll develop something called HNPP, or hereditary neuropathy with pressure palsies. Patients with HNPP usually will come in with having multiple median neuropathies, or they'll have ulnar neuropathies, they'll have foot drops. And I just thought this gene is actually really interesting to talk about, because there's not many genes where having too many or too few can produce two different conditions. So I thought that would be kind of, to me, that's kind of cool. The MPZ gene, it's the second most common genetic malformation, and this also is an important protein found in myelin. CMT type 2, about 50% as common as CMT type 1. It's also autosomal dominant, and the most common form is due to mutations in the mitofusion 2. And it produces an axonal form, and it tends to not have as much hand involvement as CMT type 1. CMT type 3, it's autosomal recessive, and you'll see these patients will usually present earlier than the other CMTs, so they usually present at birth or early childhood. And CMT type 4, also autosomal recessive, and these usually are seen more commonly in children and can sometimes present with delayed motor milestones, meaning children don't walk at as early as they should, or don't crawl as early as they should. And a lot of patients with CMT type 4 will also begin to develop distal weakness by the time they're about 5. Another interesting variant of CMT is CMT type 1X, which is actually X-linked dominant. And it represents about 12% of CMT cases. So both men and women can have symptoms, but because of its X-linked nature, men tend to have more severe disease than women, because men only have one X chromosome as compared to women who have 2. Another very interesting thing about this type of CMT is these patients can also have brain lesions. So this one doesn't just affect the peripheral nervous system, it can affect the central nervous system as well. So a question that sometimes comes up when I give talks on neuropathies is where can I actually get genetic testing? So here with our group, we use a variety of companies. So you can either get it through Invitae, through Athena, and also through GeneDx. So I wanted to talk about some of the other less common polyneuropathies. So you can have neuropathies caused by medical illness. A common one that we'll see here is critical illness neuropathy. So this can happen to patients most commonly when they've been in the ICU for a long time. And they don't actually necessarily have to have been admitted for a neurologic reason. I've seen patients who were in the hospital who were admitted for cardiac reasons, and they ended up developing critical illness neuropathy during their hospitalization. Another interesting one is Sjogren's disease is also associated with neuropathy. This one actually produces a sensory neuropathy or a sensory ganglionopathy. And then you can have toxic neuropathies. I've seen a lot of this lately. So patients who were diagnosed with cancer, underwent chemotherapy, and then developed neuropathies following the chemotherapy after they completed chemotherapy. You can also see neuropathies with heavy metals, things like arsenic, and medications like amiodarone have been associated with neuropathies. We also will check for vitamin deficiencies because both vitamin B12, vitamin B6, and serum copper can cause neuropathies. Interestingly, vitamin B6, the deficiency, so having a low vitamin B6 can cause neuropathy, but also having a very high vitamin B6 can also cause neuropathy. So sometimes it's a fine line to walk. But I thought that was kind of interesting because it's probably the only vitamin that I can think of that both a low level and a high level can be associated with neuropathy. So after a patient has been diagnosed with neuropathy, we kind of move on to the symptomatic treatment and the management of neuropathy. So one of the most common complaints is neuropathic pain. So I generally think of the medications kind of in three classes, either anti-epileptics, antidepressants, or topical. So anti-epileptics, which are medications that formerly were kind of used to treat seizures, but now more commonly are used to treat neuropathic pain. Medications that were commonly used are gabapentin and Lyrica. Also, antidepressants can be very effective for treating neuropathic pain. I really like Cymbalta or duloxetine. It tends to be pretty effective, but also tricyclic antidepressants like amitriptyline or nortriptyline can also help with neuropathic pain. So I also like topical treatments, so compound creams that usually are made at compounding pharmacies, also capsaicin cream, and also over-the-counter Aspercreme tends to be very effective for neuropathic pain. I usually will either use topical creams kind of in a combination with some of the other medications, or sometimes if a patient has very sensitive to medications and they feel like they have a lot of side effects, sometimes we'll start with a topical cream just to see if we can give them some symptomatic relief. Additionally, other treatment and management options are if a patient has weakness, I'll sometimes send them for physical therapy or for assistive devices, or if they have something called a foot drop, which usually with a foot drop, what patients will notice is that they have difficulty kind of lifting their feet or ankles when they're walking. I'll send them for orthotics. So this is an example of one of the orthotics. This is an AFO. It's an ankle foot orthotic. And what it does is it helps keep the patient's foot flexed so that it's easier to walk. Also, if patients are having imbalance with walking, I'll send them for physical therapy with gait training, which tends to help a lot. It helps with balance, and it tends to prevent falls. So thank you so much for allowing me to speak to you guys about polyneuropathies. I wanted to talk a little bit about our group. So again, I'm a member of the Neuromuscular division at UTHealth Neurosciences. We're a group that specializes in the diagnosis of polyneuropathy and other neuromuscular disorders. We offer a variety of electrodiagnostic tests as well as nerve, muscle, and skin biopsies, and we all strive to provide a state-of-the-art medical management of neuromuscular disorders. Thank you for your time.